Hello, I'm Belohlavek, and I'm a cardiologist intensivist from Prague, Czech Republic, and I'm also the chairman at the moment. And it's my great pleasure, and thank you for inviting me to have a short talk on ECPR, on out-of-hospital cardiac arrest. I don't have any special disclosures. Let me show this patient who has been treated at my institution actually 13 years ago and died of refractory cardiac arrest. At that time, we didn't have an ECMO and we didn't have anything to help, and she died after 2 hours of CPR. At the moment, we have an ECPR, which is extracorporeal CPR, which means continuation in CPR using mechanical circulatory support. And basically, almost in all cases, we use veno-arterial extracorporeal membrane oxygenation, so VA ECMO. You can see nicely that this is easy cannula in the venous part, the circulation pump, oxygenator, and arterialized blood coming back to the arterial tree. And this is a patient on the right-hand side of the slide showing being connected to VA ECMO after prolonged CPR on the ventilator and totally dependent on VA ECMO. Mechanical support has been used extensively in the past couple of years, and you see the rising incidence of ECMO, and you can also see from this paper rising incidence of extracorporeal CPR. This is also registered data on 1,796 patients, showing that the number of cases rise steeply. However, the survival remained basically the same, despite the fact that there's been an increase in age and comorbidities over time. It's a controversial intervention, actually, and from the ethical point of view, we have an uncertain risk-benefit profile for this intervention. We are not able to ask the patient whether the patient would actually like to have this intervention, so we are not able to get an informed consent. It's high costly, it has a grave prognosis, it potentially harms patients by failing recovery and bridging patients to nowhere. Some of those patients have prolonged stay at the ICU, and sometimes we actually avert the short and fast death, ECPR, and open a chance, close a chance for a good death, which is not good for our patients. What is the evidence for this? It's actually very small, and there's been so far as I know, no randomized trial finished that would show the results of ECPR versus standard care. This is an example. It's an old video, almost 8 years old, of one of our first patients undergoing ECPR. You see a team at the cath lab taking care for a young patient with refractory rehab, ventral fibrillation. The patient had 9 defibrillations for VF, and after 35 minutes, while he was on the cath lab table. And now the question is, who would be able to randomize a patient like this if we do have a ECMO? And probably many of you would connect the patient immediately to ECMO ECPR. This particular patient was successfully connected. You can go on, and you'll see in a minute that it's connected within basically 7 minutes to extracorporeal circuit. And this is here is venous arterial and the ECMO on the left, and the ECMO left hand side. And this particular patient actually survived. However, you can see another patient over here. This was again the patient with out-of-hospital cardiac arrest, had a STEMI, acute thrombosis in 2 stents. He had a CPR of 45 minutes, and ECPR, a lot of drugs for blood thinning. And as you can see, the patient was bleeding from everywhere. He got 15 units of red cells, 16 units of fresh frozen plasma, 4 units of platelets within the first 24 hours, and the patient died in next day in a refractory multiple organ dysfunction syndrome. So the question is, do you still think that this is easy to randomize those patients? It's really necessary to get the randomized data to assess whether this intervention is favorable for the patient or not. This is one of a large systematic review and meta-analysis showing that patients with cardiac arrest on the right-hand side did have a better 30-day febrile neurological outcome. You see nicely that patients, which were more than 3,000 of them, had 13% higher 30-day survival and 14% more occurrence of normal neurological outcome compared to control patients. This was interpreted in the still current European Resuscitation Council guidelines that ECPR should be considered as a rescue therapy, and there is an urgent need for randomized studies of ECPR. This is some of them, and this is 6 randomized trials which are ongoing at the moment. Some of them stopped. A multi-center trial from Maastricht has randomized over 100 patients so far. A small study in Michigan. My last information was about 6 patients randomized. I didn't get the data from Paris, but maybe during the presentation you already heard about those data. And our study has randomized recently more than 260 patients, and the study is going to be finished within a couple of days or weeks. So we'll have a first result from our ongoing trial. Where those patients come from, this is also controversial. As you know, cardiac arrest occurs outside outside the hospital, and data we have is from CPR registries, in-car registry, and from the TTM trial, for example. And those patients are successful ROSCs, meaning return of spontaneous circulation. And those patients are not only 30 to 40% of all patients. The remaining 60 to 70% are patients who are dying of refractory cardiac arrest. And it's quite controversial or questionable. What is actually refractory cardiac arrest? There have been studies showing that 10 minutes is refractory. Paris study has shown 30 minutes considered a refractory cardiac arrest. But another study from Canada showing that around 15 to 16 minutes, this is a good time to consider cardiac arrest to be refractory. 4 to 6 patients are eligible for ECPR approach, and this has been shown for, at least by 2 studies, that just a limited number of patients is suitable for this very invasive approach. The problem is that the patients with a long cardiac arrest, you see the patients over 15 minutes, a very poor prognosis. In this the United States study, the chance for survival was below 2%. So this is very sick patient population, and chance for them to survive is rather limited. Moreover, other determinants are crucial to have an acceptable outcome, and the factors for good outcome in the CPR is mainly the early recognition and EMS alert, so to call for help fast, and also bystander and telephone-assisted CPR. This is basically the most important part of a pre-hospital CPR before the professionals come to the scene and start a chain of survival. So time and logistics is extremely important. And you see this randomized study showing that patients with shockable rhythm who had a pre-hospital layperson CPR had much better prognosis than those who did not. What is our approach? We use cath lab as a place where we admit patients with refractory cardiac arrest, and you see nicely the picture of a cath lab being prepared for admitting a patient under ongoing CPR. We have an ECMO device, we have echo machine for urgent diagnosis, a ventilator, suction device, defibrillator, gas carbon plate, and of course a team consisting of intensivist, interventional cardiologist, usually ICU nurse, 2 cath lab nurses, perfusionist, and the data manager. So on this video, you can see the real life case of a patient who is being admitted under ongoing CPR. The cath lab and the team is being prepared. The patient is en route to hospital. Here you see a emergency service crew coming in with a patient under LUCA CPR. It was again a young male with several unsuccessful defibrillations for ventricular fibrillation. Here you see how the LUCAS CPR is effective. Cannulation on the CPR, insertion of the cannula during this initial cannulation and trial of stabilization. We also perform initial diagnostics. So you'll see the echocardiography diagnostics right here, and this is the echo picture. Also monitor tissue perfusion. You see the perfusion in this particular patient was very, very low. In the meantime, you see the insertion of the venous slide venous line right here. So the cannulation of arterial line has already been done, and here the cannulation of the venous line has been done, and the patient is still under ongoing CPR, and he was still under ongoing rehab. And this is extracorporeal circuiting prepared for connection, and after preparing, the circuit is being connected, and this is a connection to arterial line. And in the meantime, the patient was connected to the venous line, and ECMO was started, and the patient is on the extracorporeal circuit of 436 liters per minute. We go ahead straightly. This is how it's been cannulated. Cannulation is important, and you'll have a other talk on cannulation. This is a vein, this is artery. We look for occluded arteries, which is right here. With this proximal LAD occlusion, the most important reason for refractory cardiac arrest being ischemia, and on the right-hand side, the vessel after PCI. This is one of her patients, 75 minutes on Lucas. The patient has severe dysfunction, had LVAD, and ultimately transplanted. So what is an optimal patient for ECPR? Patient with refractory cardiac arrest, at least 16 minutes, no comorbidities, witnessed cardiac arrest either by EMS or on the public place, assumption of correctable cause, shock algorithm, intermittent ROSC patients, of course, short transport time to get to hospital or get to the patient. So let me conclude briefly that for the clinical consequences, we have to consider not ECLS alone, but the comprehensive approach, including ECLS, may have an impact on logistics and the care for our patients. With technology, we still need to define proper patients and optimize logistics, and that the randomized studies are absolutely necessary, and everything else being just an emotional bias, because we are really intimately sad to have our patients dying from refractory cardiac arrest. Thank you for your attention.